This conference will now be recorded.
All right, here is a patient. This is a really nice case that shows, I believe,
I don't
in
see your
part.
screen yet, Howard.
Okay, let me see if I can go back and.
I'm able to see your CT.
Now I
Now
see
it's
it.
good.
Okay.
Nice.
Okay, good. So this case is going to show what I think in part is a very substantial anchoring bias where for some reason a particular diagnosis is considered at the onset of the case and people hold on to it for a long period of time and don't consider plausible alternatives. So here is two images. Here is the timing, 2 years apart. And here you will see that the lungs look fine back then. The history is that this patient had a partial esophagectomy with creation of a tubularized gastric conduit. Back in 2018, we have very extensive ground glass attenuating opacities, central lungs, mostly in the upper lobes, but also the lower lobes, consistent with consolidated lung. And I think it's reasonable that I don't have thin sections, that this may have been considered maybe a subtle case of crazy paving. Let me bring up another one, 2019. Very similar findings. Consolidative opacities or ground glass attenuating. Many of the opacities are located about bronchovascular bundles, as you see there. Let's go forward in time even more. 2019. Actually, before I want to get to 2021, a diagnosis that was strongly considered was alveolar proteinosis. And he had whole lavage, and I'll show you the path in a moment. But the findings on path were not really strongly supportive of the notion of pulmonary alveolar proteinosis. But that diagnosis persisted for quite some time. So let me go to 2021 here. Pretty much the same findings, except more of it. But a notable change over time, as you can see here, is that in addition to the fact that there is more tissue per unit area, there's also architectural distortion. And the margins of these opacities are ill-defined with adjacent lung, some architectural parenchymal distortion. But again, you can see in many locations that the opacities are quite close to relatively proximal airways in many locations. So let's take a look at this. And I don't know if this observation was made back in the day, which is 2021, but anyone want to make an observation on this one?
Looks very low density. The
Yeah,
lung
excellent.
parenchyma.
Yeah. So back in then, you can see very low attenuation. Let me bring in a ROI. So let me pick a spot, say, over here. So here we have minus 50. Let's pick another spot, say, particularly around here. Exactly right. Minus 58. So what kind of history would you really push for in a patient with this progression over time, persistence over time, these imaging findings, and a patient with a gastric conduit?
Good story for aspiration.
Yep,
Mm-hmm.
right, exactly. So let's go to the most. Now we know what's going to happen over time because this is such a typical occurrence over time with the diagnosis being exogenous lipoid pneumonia. This kind of appearance to the opacity is rather typical. There's a tremendous granulomatous response. These begin over time, of course, to look very mass-like when they're solitary. One can see how a diagnosis of malignancy might be entertained. But look here how low attenuation we have in the center. So there's a lot of fat in that location. So exactly that. And eventually they did get that history of regular mineral oil use right here. And eventually in 2022, they did transbronchial biopsy. Here are some annotated images. So I need to fix that, which I can. And here you can see very typical findings of exogenous lipoid pneumonia. We see the spaces previously occupied by lipid. We see the tremendous granulomatous response, giant cells engulfing the lipid material. So a very nice case of exogenous lipoid pneumonia. Really a very delayed diagnosis of it. And we can see that he had at least 2 whole lung lavages. And here you can see no really strong supportive evidence for alveolar proteinosis. They eventually evaluated GM-CSF antibody tests negative for that. Nice case, huh?
Yeah,
Absolutely. That's a great
beautiful.
one.
Yeah. Yeah. Oh, here's some nice crazy paving there. So it's one of the classic causes of crazy paving, actually. Acute exogenous lipoid pneumonia, that is, can be very crazy paving like at times. I don't know why, but it's
Yeah,
way
it's
up.
in, well,
Sure.
I think it's probably just because, I mean, it's sort of along the spectrum of, ground glass to consolidation with maybe some lymphatic clearance. But it's in that, there's that old paper in radiographics on crazy paving that Santiago Rossi did, and they show lipoid pneumonia in there. So, yeah.
Yeah.
But it usually causes more distortion, and that can be a clue compared to, other things that are more filling the lung.
Yeah.
You see some, it looks more distorted on your case, but that's great
Yeah.
example.
Very good. And then also the appreciation that the smaller opacities are in close proximity to airways. And it makes sense. That material just comes out of the airways, deposits, and has a bronchovascular distribution as well. All righty. Very good. That's my case for this week.
Thank you, Howard. All right, Maya, you can go next.
All right. Go, computer. There we go. Okay. So I have 2 cases today. Both of them are device related. So this is the first one. This is a relatively young patient who has a history of postpartum cardiomyopathy and was brought to our hospital in sort of acute on chronic cardiogenic shock. You can see that at this time point she has ECMO cannula in. And at some point during her hospital stay, they decided to convert the ECMO, due to a slight improvement in her status, convert the ECMO to an Impella device. So we can see the Impella here. And if we follow it, we can see the catheter portion of it that extends outside of the body, but it's taking a slightly unusual course. So oftentimes these may be placed via the lower extremity, in which case that catheter will come up the aorta before looping down into the left ventricle. But they can place it from the upper extremity. Usually they go through sort of the the axillary artery, axillary artery. But usually, again, I don't know, it's not quite the right course for that. So she actually ended up getting a CT, and we can see where this Impella was placed. So here's the Impella in the aorta, and if we continue upwards, we see that they actually put a graft onto the aorta specifically to place this impella. And it sounds like from the op note, the reason they did that was the patient's axillary arteries were too small to accommodate the impella, and they were going in to do a tracheostomy as well as, I think, in addition to removing that ECMO cannula. And so at that time decided that the best approach to placing this impella was by creating this sort of little graft chimney coming off the anterior aorta so that they could place this device directly into the aorta through that.
Oh, yeah.
So I've not seen that done all that frequently, but it was just an unusual appearance on the CT and the X-ray.
Yeah, that's neat.
Yeah.
Yeah, I've seen that on 2 occasions. And the other thing that is worthwhile knowing about that is that in a patient that recovers, they remove the impella, but the synthetic graft that they use to put it in remains.
Mm.
And if you just happen to read a post-removal CT and you see another tubular structure in the superior mediastinum that doesn't make any sense, that is the potential explanation. So I've seen a case like that where we puzzled over what looked like a tubular opacity, we thought, and it turned out to be the not removed, not completely removed graft, synthetic graft, through which they had placed the impeller device. So that's just a gotcha
Cool.
potentially down the line.
Nice. Excellent. All right, so that's a quick one. This is my other case. So this patient came in to get pacemaker replaced. And, as is typical after pacemaker placement, we get a 2-view radiograph, frontal and lateral, so we can look at the lead positioning. And this is how this patient's pacemaker looked immediately after placement or the day after placement. Patient went home and then a day or two later came back in with really severe left-sided shoulder and neck pain. And so they interrogated the device and found that they were not having good lead capture on the RV lead. So they did an echo, which showed some concerning findings, and then they went to CT to confirm those findings. So here's our patient's CT. We can see those dense leads coming down through the SVC. Here's our atrial lead, which is going up into the right atrial appendage. That looks appropriately placed. And then here's our ventricular lead, which extends across the middle of the ventricle, goes through the septum, outside of the heart, across the diaphragm, and is touching the stomach.
Oh.
So not ideal placement, but explains, one, why they're having pain, as well as why their lead is not functioning appropriately. So we even have some nice little 3D images of this going all the way through and then out towards the stomach. But
Did they
patient did okay. They removed it and they patched up a hole. So they had to go in operatively to take this out.
how did they posit it moved through that many layers of tissue in a short period of time?
I have
Really?
no idea. I
Because
mean,
it looks like it
part of
was
me
well
wonders,
positioned when they started.
yeah, and realistically, this CT was done one day after this X-ray. So it makes me wonder whether it's just that it was already down there touching the stomach on the X-ray, but it looks just like they usually, I don't know.
Yeah, that may
This
be very
X-ray
true.
didn't strike me as being that abnormal. So, but yeah.
Yeah, that's puzzling that it went through so much tissue to get
Hmm.
to the ultimate location. That is startling.
Yes, agreed.
So, but if you look at coronal CT on that case with
Yeah,
the pacemaker perforation, see the left hemi diaphragm is really high. So
it
in a way,
is.
the stomach has come up to meet alongside the heart, and I think that's why you really got this striking course here. It's because the diaphragm and the stomach are in the wrong place. So
Mm-hmm.
perforation here has different consequences from what it would have if the diaphragm were lower and the stomach
Lower.
were out of range. It would have just
Yeah,
gone into the lung at that point.
that makes sense. Uh,
Jeez.
but yeah,
Just another
anyways,
problem with deventration.
correct. But yeah, patient is doing fine. They took the lead out, repaired it, and they went home and are doing just fine. But anyways, those are my cases.
Excellent. All right, David, welcome. Do you have any cases this week?
I do.
All right, you may go ahead.
Mixed connective tissue disease, a component of lupus, and a myopathy related to lupus. And so this person has extremely low lung volume. This is from like 2004 or something like that, a long time ago. If we look at a CT scan in that era, we see that there is a decent thickness of diaphragm muscle posteriorly here on both sides, on the crura and posterior diaphragm, and anteriorly diaphragm, a little bit thin anteriorly here on the left, pretty close to normal on the right. And this condition persists. Notice the atrophy of spinal muscles here. There's just, and all of the thoracic muscles have fat infiltration. They're speckled with fat, and they're pretty scrawny. And the pectoral muscles also contain a lot of fat. So this is part of this lupus myositis that this person has. And things are only worse now. So a current CT scan here is here's 2023, so this is current, and you can see that these the fatty infiltration here of the crura is a little more pronounced, and there's a little bit less muscle tissue, more fat, less muscle, and again this profound atrophy of all the thoracic muscles. So this low lung volume here reflects this lupus myositis. I've not seen this condition before, so I haven't read up on it yet, but this just came through yesterday. Look at the fatty replacement here of pectoral muscles. Okay,
Wow.
so
That's pretty remarkable.
sorry about the patient information there, Jeff. Will you be able to filter that out? I hope.
Absolutely.
Thank you. Sorry about that. This person has a lot of lymphadenopathy that developed, was not there in 2021 on an earlier CT scan, but the current CT shows this massive amount of hilar and mediastinal lymphadenopathy. The lungs themselves are clear. This person is on Humira for inflammatory bowel disease. There may be a little bit of bronchial wall thickening here, but there's no profusion of small sarcoid-like nodules. Nodes were biopsied, and they returned non-caseating granulomas consistent with sarcoid. So we think this is it's kind of a secondary sarcoid or sarcoid-like reaction in the setting of this Humira therapy. So I've shown a case related to a nivolumab a few weeks ago, and here's a case related to Humira of sarcoid-like reaction in the setting of inflammatory bowel disease.
Yeah, it seems to be more common with TNF alpha inhibitors than checkpoint inhibitors, the sarcoid reaction.
Okay.
I've also seen it with interferon.
Yeah.
People getting interferon for
Hepatitis C.
Got it. Okay. Yeah, I think I had a case of that too. Okay. Okay. Actually, Jeff, I think I might need to check this case before I show it. So can you go on to, oh, actually, we're okay here. I can go ahead. Okay. So this person has really just a classic set of findings here for a very nice bronchogenic cyst. So slightly high attenuation in this subcarinal lesion here, which is kind of leaning on the top of the left atrium a little bit, and so forth. And this thing had gotten slightly larger over the course of the last year and a half or 2 years. It has slightly higher attenuation than muscle. Down here is like 60 Hounsfield units. It's very uniform though. And on MR imaging, let's see, I think this is the one that shows it's consistent with proteinaceous fluid here. Let me get the right sequence for you guys. I think this may not be it. Yeah. So sort of not as white as CSF here, so consistent with proteinaceous fluid here, very uniform. And so this is a classic findings for bronchogenic cysts. Because this lesion thinks it's a bronchus, it's busy producing bronchial mucus, which is proteinaceous, and that's why it has higher attenuation than water. So pericardial cysts have low attenuation. They're called sometimes spring water cysts because it's just like water, usually less than 10 Hounsfield units. The bronchogenic cysts have a protein component, so they have slightly higher attenuation. Classic location here. So just a nice example. Okay, guys, that's it.
Very nice. All right.
Awesome.
Here are a few cases real quickly. All right. So this first case this is a newborn, and you can see the heart mediastinum look very abnormal. And so the diagnosis was not in question, but they were trying to decide if this was a reparable abnormality. And you can see we have an extrathoracic heart. So we have ectopic cordis. And you can see there are we look at the structures here. So here's the inferior vena cava. Here's the left atrium and the pulmonary veins. And we can see there's the aorta coming off, but it's actually it's an interesting aorta because there's a PDA, there's an interrupted aortic arch. So here's aorta coming off. So we follow that. There's PDA, and you can see the PDA communicates with the descending aorta there off the pulmonary artery, and that the aortic arch, which is here on the left, terminates in a left subclavian artery. So it's an interrupted aortic arch. And the descending aorta is perfused to the patent ductus arteriosus. So it's common when you have an interrupted arch to have anterior abnormalities. But often you think of DeGeorge syndrome with thymic aplasia, and they can have other midline abnormalities. But in this case, this is ectopic cordis. But this was not repairable, unfortunately, because of the anatomy and other complications. But very rare diagnosis. Often don't even make it to CP.
Was this DeGeorge syndrome, or have they not characterized that yet?
I don't know. It may very well may be, but I don't have the details on that. All right. This was an interesting.
So Jeff,
yeah.
Can I just throw in something? This is tangential.
Of course.
So I get upset with the residents who will say that the nasogastric tube projects over the tip projects over the stomach. You know, just really sort of pussyfooting around the notion that we don't know for sure that it's inside the patient. So I counter that by saying if you're going to be fair, you should say that the heart projects over the chest, because we're not sure it's actually in the chest. And now you presented me with an example that just destroys my argument here, so I'm really resentful.
Yeah, I'm sorry, David. Yeah, the heart does project over the chest in this case. All right. So this was an interesting case. So this patient presented for evaluation of a persistent pleural effusion, and you kind of got this blobby effusion. It's mostly layering down here. There's a little bit of atelectatic lung, but there's really not much else going on with the pleura. I will point out a few areas. If you look along the costal pleura here, it looks pretty normal. Probably just a little bit of pericardium there. And we go up a little higher. There is a little bit of this pleural fluid tracking a little bit medially, but just looks like a big pleural effusion. If you look at the underlying lung, there's a nodule on the other side. There's a lot of atelectasis associated with it. So they evaluated this pleural effusion, and lo and behold, and this is something they can do now with some new staining. This is a mesothelioma, and it's kind of an odd one. I've seen a few present as sort of these loculated effusions, but usually they have a pleural rind or some soft tissue component. Now this is non-contrast, but usually you still can make out the tissue, and you see the thickening along the fissures. Even this fissure here is just minimally thickened at most. So just a weird one, but there's a bunch of new immunocytochemistries they can use to make a diagnosis of mesothelioma, which in the past you used to have to get a pleural biopsy showing invasion of the extrapleural fat, because these mesothelial cells look like reactive ones. But this was an odd one. I haven't, we're not seeing as many mesos anymore, but I only remember maybe one or two that presented more as just a loculated effusion like this. David, you and Howard, you've probably seen more than I have, but
Yeah.
do you recall ever seeing ones that sort of don't have the typical rind? I've had a couple as a mass, but not just as a sort of loculated effusion.
Can we look some more at the mediastinal pleural surfaces a bit
Yeah,
higher up?
right, because that's exactly, you want to look at some of those interfaces. And the only area is just way up high, right in here, coming off of this effusion, but maybe subtle there, but
Yeah,
And the
it's certainly like
that's
there,
about it.
right
It's
there.
not
If
your,
you stop right
yeah.
there, even though that pleural surface is slightly thickened, one should
Hmm.
always view that with suspicion in a person
Right,
with an undiagnosed pleural effusion to start with. Even that degree of mediastinal pleural thickening is always concerning.
right.
the other thing, Jeff, is that sometimes they're mixoid, and this kind of looks mixoid. So I wonder if this is really, was this really liquid? Was it really effusion, or was it just sort of a gelatinous tumor?
That's a good question. I don't know because no one went in there surgically. Of course, it was done with a thoracentesis.
Hmm.
Yeah, I know they analyzed they did the cytology is how they made the diagnosis. So you may
Very
be
well.
very right. I have not seen any follow up on this case. So, but
Hmm.
just a little bit odd. All right, and
Very
then
odd.
this last case is kind of a fun case. I was going to show it previously. Let me get these dates right here. So this is an old scan. So you can see this patient has a very abnormal lung, and I wish I had a radiograph, but I don't. You can see at this point there's a small caliber pleural drain in, and we have these cystic spaces here, and then up high you have this hyperlucent lung and this dilated bronchus that comes down there and kind of just ends, and a couple of other dilated blind ending bronchi. So this is a patient who has bronchial atresia, and it's interesting because it's in multiple segments. And then I suspect this is a little CPAM down here. So congenital lesion, and then let me get that's the right one. But what happened is this patient, yeah, then developed an infection in there, and so they developed this consolidation and cavitation around these airways, and you can see a bunch of small inflammatory nodules around it. So I've not seen bronchial atresia. We always think of it as a don't touch lesion. I've not seen it lead to an infection, and I don't know if they just happen to get infected in that region, in that area. But it seems to me it's right where all of these blind ending bronchi are. So maybe the bug just got in there and found a nice place to set up shop. But I can't recall. I've seen sequestrations get infected, but I've never seen bronchial atresia cause an infection.
Hmm.
I think I've seen one case many years ago in which a patient with bronchial atresia developed an infection with Aspergillus, which was a surprise the organism.
Hmm.
And of course, we speculated about the occurrence of that and the bronchial atresia together. So maybe once, I think I may have seen it once in my career.
Okay. Yeah, because I always think of it just as a benign process that it's been there their whole life. It hasn't caused problems. But I mean, in this particular case, resection is not really an option because it's so multifocal. It's just it's an interesting bronchial atresia because it's involving the left upper lobe, which we see, but then it's involving sort of another segment down here, and then you've got
Yeah.
another area down here in the right left lower lobe, and I'm convinced this is a CPAM. So yeah, just an interesting one. Okay, well that's what I have.
Yeah,
I will
very nice case.
send you guys this and last week's cases. So we'll stop here today, and I'll talk to you all next week. And David, I'll scrub that information out.
Okay.
David, did you perhaps see the case that I showed first? Were you on at the time?
I was